Hey everyone, welcome to this explainer. Today, we're meticulously unpacking the syndrome of inappropriate antidiuretic hormone secretion, or SIADH, point by point. We are leaving absolutely no critical detail behind. Whether you're gearing up for clinical practice or just really want to nail down the physiology, this explainer is designed to clear up your concepts entirely, so you can ditch the textbooks. Let's get right into it. Okay, here's our game plan for today. We're going to cover what exactly SIADH is, how we diagnose it along with its symptoms, treatment, and fluid management, the very real risk of osmotic demyelination syndrome, and finally, treating the underlying causes. Let's jump in. Section 1. What is SIADH? First things first, we really need to establish what this condition is actually doing inside the body. At its absolute core, SIADH is the release of antidiuretic hormone, or ADH, also known as arginine vasopressin, in the complete absence of any normal physiologic or osmotic stimuli. Basically, your body is releasing ADH when it really shouldn't be. Because of this inappropriate release, you end up with hyponatremia alongside hypervolemia or euvolemia. And here's the wild part. This massive fluid expansion happens entirely without causing edema. Crazy, right? Now, this brings us to a massively important distinction. You absolutely must differentiate SIADH from cerebral salt wasting, or CSW. Both of these are going to give you low sodium. But while SIADH presents with hypervolemia or euvolemia, CSW presents with hypovolemia. You've got to get this right early on because the treatments for these two are basically polar opposites. It's a real make-or-break clinical moment. Moving right along to Section 2, diagnosing SIADH and symptoms. Let's break down exactly how clinicians identify the syndrome point by point. At a high level, locking in a diagnosis requires three big pillars: hyponatremia, inappropriately concentrated urine, and absolutely no evidence of renal or adrenal dysfunction. Sounds simple enough, right? But to truly confirm SIADH, we have to drill down into 8 very specific metrics. All right, looking at this first batch of criteria, what's really fascinating here are the precise numbers. We're looking for a low serum sodium, usually under 134 milliequivalents per liter, and a low effective serum osmolarity under 275. But check out that third point, a paradoxically high urinary sodium, greater than 18, and honestly often hitting anywhere between 50 and 150. Medical science hasn't totally nailed down exactly why urinary sodium is so high in SIADH, but it is a classic hallmark, right alongside a high ratio of urine to serum osmolality, often sitting around 1.5 to 2.5 to 1. For the second half of our criteria, it's all about ruling out other organ issues. You've got to have normal renal function, meaning your BUN is commonly under 10. You also need normal adrenal function and definitely no hypothyroidism. Finally, to confidently confirm this diagnosis, you have to verify there are 0 signs of dehydration or overhydration. So what happens in those tricky cases where serum or urinary ADH levels aren't directly measured? Well, that's where the water load test comes in as our definitive diagnostic tool. Here's how it works. The patient drinks 20 milliliters per kilogram of water, up to a max of 1,500 milliliters. Then we measure their water excretion over the next 4 to 5 hours. If they fail to excrete 65% of that water in 4 hours or 80% in 5 hours, that directly indicates SIADH. But hold on, you have to be incredibly careful here. You must never perform this water load test under certain conditions because the safety risks are just too high. If your patient's starting serum sodium is 124 or lower, or if they are already showing symptoms of hyponatremia, loading them up with water is incredibly dangerous. It's an absolute contraindication. Just don't do it. Speaking of symptoms, how do these folks actually present? Bizarrely enough, they often show up with a paradoxical, totally inappropriate thirst. And honestly, if they are showing symptoms, you can pretty much guarantee their sodium has already plummeted below that dangerous 120 to 125 range. All right, Section 3, treatment and fluid management. Once you've got the diagnosis, your management strategy is strictly dictated by 2 things: the severity and the duration of the hyponatremia. For the severe cases, we rely on very specific IV fluid and furosemide combos, but you've got to pay attention to how the saline concentration flips based on the timeline. If the condition has been going on for less than 48 hours, or if you're seeing severe symptoms like a coma or seizures, we hit it with 3% saline at 1 to 2 milliliters per kilogram per hour, plus 20 milligrams of IV furosemide daily. But, and this is a big but, if the duration is greater than 48 hours without those severe symptoms, the protocol shifts. You switch to normal saline at 100 milliliters per hour while keeping that daily 20 milligrams of IV furosemide. Now, this table brilliantly maps out exactly how to titrate fluid restriction based entirely on the patient's solute ratio. If that ratio is greater than 1, you've got to clamp down hard on their fluid intake, less than 500 milliliters a day. If it's exactly 1, they get a bit more, say 500 to 700 milliliters. And if that ratio drops below 1, they get a bit more leeway, up to 1 full liter a day. Moving to Section 4, Osmotic Demyelination Syndrome Risk. This is where things take a serious turn. We really need to talk about the dramatic, life-altering dangers of correcting these sodium levels too quickly. These hard numerical limits you see here, they are the absolute golden rules of treatment. They exist for one reason: to prevent catastrophic brain injury. You absolutely do not exceed a correction of 1 milliequivalent per liter per hour. On top of that, do not exceed 8 in a 24-hour period or 18 in 48 hours. Whatever you do, do not rush to correct their levels to normal or supernormal too fast. Because here's what happens if you overcorrect. Osmotic demyelination syndrome, or ODS, which includes central pontine myelinosis. It's a devastating complication caused by treating hyponatremia too rapidly. It produces an insidious onset of flaccid quadriplegia, profound mental status changes, and pseudobulbar palsy. It is literally destroying the brain's white matter. Let's take a look at these visual representations, styled here in a really cool watercolor theme. You can clearly see where the severe demyelination damage is happening right within the central pons. That's the central pontine myelinosis you're seeing on the left. And on the right, you can see how that osmotic demyelination extends out into extrapontine areas like the thalamus. It is a profound, devastating structural breakdown of the brain. Now, the patients most vulnerable to this kind of brain damage aren't just the ones who get their sodium corrected too rapidly, though, to be clear, jumping more than 25 milliequivalents within 48 hours is a massive trigger. But other huge risk factors include overcorrecting folks who have hepatic encephalopathy, or patients dealing with chronic, debilitating diseases, malnourishment, or alcoholism. You also have to be on high alert if the hyponatremia was present for more than 24 hours before treatment started, or if there was a diagnostic delay combined with respiratory arrest or hypoxia. Finally, Section 5, treating the underlying causes. To wrap up our clinical pathway, we have to step back from just managing the fluids and actually target the root of the problem. At the end of the day, fluid management and saline infusions are really just a bridge. The only definitive treatment for SIADH is identifying and knocking out the underlying etiology. If it's being driven by anemia, it usually responds well to a blood transfusion. If a malignancy is the culprit, it might respond to anti-neoplastic therapy. And if it's drug-related, simply discontinuing the offending medication usually clears it up rapidly. So as you take this deep dive and apply it to your own clinical practice, ask yourself, are you prepared to navigate these complex, high-stakes decisions? Will you recognize those subtle, crucial differences between SIADH and CSW? Remember those rigid limits on sodium correction and the severe consequences of getting it wrong. Keep these key points in your back pocket, and you'll be well-equipped for your next hyponatremic patient. Thanks for hanging out with me for this explainer. I'll catch you next time.